Thank you for joining us for Conversations and Cases in Oncology, Practice-Changing Updates in Systemic Treatment of Advanced Hepatocellular Carcinoma. During the segment, we will be just discussing practice-changing updates in different settings of advanced HCC. I am Mark Yarshwan, an associate professor at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins. I'm joined today by my colleagues, Dr. Adam Burgoyne and Dr. Rachna Shroff. So the topic of this session is really initially the perioperative setting. In almost every other tumor type where we have highly effective systemic therapies, we're using those systemic therapies not just to prolong life in the advanced setting, but also to try to achieve cure. So I want to start by talking about the adjuvant setting. And just in 2023, we had our first ever positive study of perioperative systemic therapy in HCC. This is the IMbrave 50 study that showed that the combination of bevacizumab and atezolizumab for a year after surgery can prolong the primary endpoint of disease-free survival. So I actually want to turn this over to my two colleagues here just to sort of dig into that data. In your opinion, again, we're still waiting to see if the FDA is going to approve this in the adjuvant setting, but if you were the FDA or, as a clinician who has the option to use this already, is this something that you would reach for a patient with high risk but resected HCC?
I can start if you like. It's a hot topic, obviously, in oncology, something that we're very excited about. And obviously, everyone was highly motivated to get kind of this first data cut out so we could see that we had a positive endpoint. However, I think from the FDA perspective, from professional organizations trying to assess this data to see if it should be recommended yet, we still are a little bit too early to definitively say if this is going to provide a prolonged benefit in achieving cure, as you mentioned, or prolonging overall survival for patients. So that being said, atezo-bev is something that is on the market in the advanced space. It's something that we can access in some fashion off-label. I think that at this point, based upon the data in my personal practice, for some very high-risk patients, it's worth a nuanced discussion with the patient if it's something that makes sense to consider, but it certainly has not yet become our new standard of care.
Dr. Shroff, same for you?
Yeah, I would echo that. I mean, I think it's started a conversation and a dialogue. I have to say I've probably been a little bit slower to even maybe have that conversation with patients yet. And I think it's not because I don't necessarily believe the data. I just think, I mean, like Adam alluded, I think we need to really see how this data plays out to understand what this is doing to survival. I mean, we know there's a bimodal distribution, first of all, for recurrence in HCC. We also know that underlying cirrhosis can increase your risk of developing secondary HCCs. And so, what is the atezo-bev doing in terms of just overall survival? I think, to me, will be the key question. That being said, like you mentioned, with the FDA having, discussions about whether or not to approve it, I think it's very possible if it gets approved, it'll be implemented. But I'm a little bit slower on the uptick so far.
I mean, I know we've only seen, very early data, but at this very early time point, there's still more deaths in the group that got atezo-bev than the group that got placebo. And losing a patient in the advanced setting to treatment-related toxicity is always devastating, but to lose a patient who's potentially cured with nothing else, I think is especially challenging as a provider. So I can certainly understand the hesitancy and I share that. I think it's unclear at this point, in my opinion, whether we've sort of traded an earlier benefit for a later benefit or whether we're truly changing the disease trajectory. Obviously, a number of other adjuvant studies that are ongoing that should come out in the relatively near future, studies of PD-1 alone or PD-L1 alone, Nivo, Durva, Pembro, and then a study of Durva with or without the addition of Bev, which will really answer the question whether the Bev component is truly needed in the adjuvant setting or not. So I think these are important studies that should read out soon. I want to turn our attention to the neoadjuvant setting, and candidly, this is a particular interest of mine. So I apologize if you want to talk about something else, but we have data now from other tumor types that potentially the benefit of checkpoint inhibitor may be improved if it's given before surgery rather than after surgery, with the idea that the tumor itself can become an in situ vaccine. Maybe I'll just ask both of you, there have been a number of sort of small, single arm, single institution studies showing at least safety of checkpoint inhibitor in the neoadjuvant setting. Where do you see this kind of going in HCC, and what's your sense of the data thus far?
Well, I mean, I think that what we have seen so far, with the caveat of what you just explained, that a lot of them are kind of small and proof of principle and or single institution studies, I think it does suggest that there is, as we are seeing in other tumor types, potentially a benefit to really immune modulation in terms of overall impact on the course of a patient in the setting of kind of a pre-operative approach. I think what has been helpful to see, first of all, is that it's feasible. All of these studies have demonstrated the feasibility of giving single agent or dual IO or TKI IO combinations to patients preoperatively, completing that therapy, safely taking them to surgery, and not necessarily having to worry about that aspect of it, because there was, I think, some pushback when these concepts were still being designed and thought about. And I think, and I think you of all people can speak to this, but I think, for instance, the neoadjuvant combination studies, especially when we see very provocative looking pathologic complete responses and significant responses both radiographically and at the time of surgery, I think it really does suggest that there is a benefit to considering the neoadjuvant treatment. And that's why I think some of the larger studies that are being designed and looking at some of those questions are really going to be key.
Yeah, I agree with that sentiment. I think that, with the caveat that these are sort of small hypothesis generating studies that are going to lead the way to larger, more prospective data that will help us kind of guide the management moving forward. I think it is an interesting strategy. As Rashta noted, I think the path CR rates are very exciting for some of these small studies. And then also, I think, just as a test of disease biology, we know from other tumor types that this can be an important use of preoperative therapy. And I think we also know that there is sort of this disparate disease course in tumor biology of our HCC patients, with some of whom that behave on a relatively indolent course, and some of whom have quite aggressive tumor biology that recur rapidly after surgery. And then we usually end up taking care of those patients in the systemic therapy space, and it can be quite challenging. So not moving forward with an aggressive surgical resection that isn't going to be curative, I think also can be helpful as we learn patient selection.
I totally agree with those things. I want to switch gears a little bit now and talk about the second line. And, at least my experience has been that as we use systemic therapy earlier and earlier, as these frontline regimens move into the intermediate stage and the perioperative stage, that more and more patients are getting to second, third, even fourth line. Unfortunately, we have no data for anything officially after, durvalumab or bevatezo, but at least current contemporary guidelines from NCCN, ASCO, ASLD generally recommend a TKI in second line. Has that been your practice, and is there one in particular that you tend to reach for in that second line setting?
Yes, I think that is our standard. Most of us, I think, are reaching for lenvatinib, in large part due to extrapolation from non-inferiority data in comparison to sorafenib, but also just a slightly improved safety profile and improved tolerability of these agents. They can be a little bit tougher than immunotherapy, so that is an education point moving into the second line, that you are hopefully doing fine on perhaps your durvalumab, but now perhaps you're going to have more side effects that might be a little bit more difficult to manage. But I would echo everything that you're saying. It's a bit of a data-free zone, and sort of extrapolating from existing data from the first line and what our own experience has been.
Yeah, and I mean, I would also just maybe even ask both of you, the other question that routinely comes up that I get asked and that I think about in clinic is, in the post-atezo-bev patient, and is there a role for immunotherapy? And if so, do you gravitate towards a Nivo-IPI so that you start to think about adding in that CTLA-4 component, versus what we have and we know is available to us in a monotherapy approach? I mean, Mark, what is your typical practice in that space in terms of immunotherapy?
Yeah, I mean, I generally offer patients a TKI in second line after a Tezo-Bev. I do use a lot of Nivo-IPI in third line. And we have a small retrospective paper out showing that Nivo-IPI really does have true, meaningful, durable responses after prior PD-L1 therapy. I think there is a subset of patients, that really do benefit from that anti-CTLA-4. So that's become my default sort of third or fourth line regimen. Response rate of around 20%.
Yeah, I think we do have this question on, is there a role for durvalumab in that space? If we're really doing evidence-based medicine, it has not been studied in the second line, and Ipi-Nivo has. So oftentimes that, would be the default immune checkpoint blockade strategy to move towards. But, as we have talked about, the rates of immune-related adverse events with Ipi-Nivo are not insignificant. And sometimes as a patient is becoming perhaps a little bit more deconditioned, perhaps liver function is starting to decompensate a little bit. That's certainly a factor that comes into play for that discussion as well.
Yeah, I mean, it's certainly hard to compare a first line study to a second line study. These are totally inappropriate cross trial comparisons. But my overall impression of the data is that durvalumab is probably a little bit better tolerated. We do see lower rates of adverse events, but also the response rate does seem to be a little bit lower, with 20% for the combo versus 17% for durvalumab. With Nivo-IPI, again, different population, all sorts of caveats here. The response rate we're seeing is upwards of 30%, compared to about 15% for Nivo alone. So I think that the dose of CTLA-4 is probably higher, and so is the toxicity. But if someone's already experienced PD-L1 therapy, hasn't had an AE, it's something that I do sometimes reach for. Any other sort of closing thoughts? I want to just ask one other question that comes up a lot, at least in my practice, is if a patient receives Bev-Atezo adjuvantly, and then recurs, is that a patient that you would re-challenge with Atezo-Bev, or do you go to second line? And how quickly would the patient have to recur before you would sort of give up on Atezo-Bev?
Yeah, I think I have a tendency to, again, given that this is all data free and we're extrapolating, I think as GI oncologists, we all have this general sense of, what your disease-free interval is, and 6 months is this kind of arbitrary cutoff, right? And so I think I would think about re-challenging the further out we are in terms of recurrence, and probably have a tendency to re-challenge if we're talking a longer interval there. I mean, knowing that you have durvalumab, I think probably makes me a little less likely to pull Atezo-Bev back, given that I have that as an option. But recognizing that maybe it's something that could be used and re-challenged in the future. But I think the general gut instinct that I would have is to try durvalumab first, and then, consider how long they were off the Atezo-Bev before they recurred.
Yeah, and certainly a very relevant question. As you noted, many other adjuvant therapy studies going to read out soon. Presumably some of those hopefully will be positive. I think this is going to be a question that certainly comes up for many patients in the future.
So maybe I'll just end by summarizing quickly that, this is an exciting time to be treating HCC. We've gone from a single therapy to many therapies, and now there are real questions about sequencing. I think the key takeaways here are that systemic therapy has moved earlier, for the first time, perhaps into the perioperative setting. And TKIs now have really moved to the second line setting, but still have an important place in the overall treatment regimen. Well, thank you again for joining us for this segment, Practice-Changing Updates in Different Settings of Advanced HCC. Please be sure to click on the landing page for this activity to claim your continuing education credit, access supplementary slides, and as well as other topic segments. Thank you.